am so excited today to be interviewing my medical advisor, Dr. Yara Robertson. I met her when I first started Learn, Look, Locate. I feel so fortunate that she has been by my side, not only as one of my medical advisors, but as a friend to help me just get this going and cheer me on days when I truly needed it. And I'm going to interview her today about breast cancer surgery. And for those of us that have been through this, I don't know about you, but I surf the net like crazy, especially the night before. And we're going to have a in-depth conversation to help calm you down and empower you with all the questions that I had and now know way too much to ask Dr. Robertson. So I just want to ask you, where are you practicing and why are you with Learn, Look, Locate? How long have you been hanging out with me? And anything else?
Okay. Well, I'm Dr. Yara Robertson. I am the medical director of surgery at CARTI Cancer Center here in Little Rock, Arkansas. I actually met Cynthia online on Instagram. She reached out to me during COVID in 2020. At the time, her organization was very small, but I liked her mission and what she was trying to do. And I liked the fact that she took something that was the most difficult time of her life, having a diagnosis of breast cancer, and tried to educate young women, especially, but women with breast cancer with all the questions that she didn't get to ask and all the stuff that she had to deal with after surgery that she wished she could have had the information for before. I like all the organizations like Susan G. Komen, Living Beyond Breast Cancer, Young Survivors Coalition, but she is doing things a little bit differently. She's trying to make it non-threatening and giving a lot of information with soft backgrounds. I like the fact that she is not a nonprofit and she's doing this on her own, and that I feel like the medical advisors that she's picked have really done a great job with guiding her, giving her scientific information. She's not doing this by herself, and she's reached out and got a phenomenal team. So I really think this is a wonderful organization. I think it gives great advice, great medical advice to the patients, and it really informs the patients. So by the time they go to see their doctors, they can ask them those important questions that she didn't get to ask her doctor.
Well, thank you, Dr. Robertson. I really appreciate that. And as a medical advisor, I just want to thank you for contributing your expertise and your valuable time to help so many people that might not have access to these answers and questions in such a calming way, because you do help us feel a lot less anxious. So, with that being said, I'd love to know if a patient is newly diagnosed with breast cancer, how do they make the decision on whether or not to remove possibly the opposite breast? Like I myself had the tumor in the left breast, and it was a big decision. Should I remove the right one and just want to share with everyone? I did. I chose to do that kind of last minute. But how does one know?
Well, first of all, you have to look at your imaging studies. For instance, if your medical oncologist or your breast surgeon has ordered additional diagnostic imaging or an MRI, you want to make sure that breast is clear. A normal breast, we are supposed to tell you as breast surgeons, they call it a contralateral mastectomy, meaning removing the breast that doesn't have breast cancer. If it's a normal breast, we honestly cannot tell you to remove a normal breast because there's no cancer in it. And when we look at the risk for developing a breast cancer down the line, especially with good treatment, it's actually not that high. However, I don't talk patients into or out of removing a normal breast. What I tell a patient is it's going to be a personal choice. I like butter pecan ice cream, you like strawberry. I can't make you like strawberry or butter pecan, and you can't make me like strawberry. So it's their comfort level. I will say that if it gives them peace of mind and symmetry, especially if you're getting a mastectomy with reconstruction, or even if you're getting a mastectomy and you want to be flat, it's so that you can be symmetrical on both sides. Another benefit to removing the breast is you don't have to really get imaging studies anymore. You don't have to get that annual mammogram.
Yeah.
If you have a reconstructed breast, both breasts are reconstructed, then we order MRIs if we think we feel something, or maybe an ultrasound, but the annual screening mammogram goes away. What I always tell patients is that removing both breasts does not make your risk for breast cancer 0%. Breast cancer can come back in the fat, in the skin, in the muscle, in your liver. So removing the breasts, both breasts, do not make your risk 0%. So that's something I drill into patients. But two of my pet peeves. One is when a surgeon walks in and scares the patient into removing the breast. They will say, "You don't want to catch cancer in the other breast, do you?" Well, first of all, cancer is not COVID, so you don't catch it. The second thing is the breast doesn't cough and give the other breast cancer. And then they will say something like breast cancer will jump on that other side. Well, breast cancer doesn't wear Brooks tennis shoes and pole vaults to the other breast. That's not how this works.
Okay.
Now, in your case, and I hope you don't mind me saying, you
Oh,
made, in hindsight, you made a good choice because you had atypical cells in that opposite breast.
what
So
is a,
I so
wait.
atypical cells are cells that are not cancer. And I hate to
Okay.
say precancerous cells, but these are cells that put you at risk for a future breast cancer in both breasts. And we actually do risk reducing medication or risk reducing surgery for those patients. So in hindsight, you actually did make a very good choice. But for the average patient who doesn't have anything going in that breast, we don't recommend you remove the opposite breast. It's a personal choice. From a cancer standpoint, if it's going to, your prognosis is based upon the cancer that you have, how well you do. So what I tell patients is removing a normal breast is not going to make you live any longer, but it gives you
Okay.
peace of mind.
Mhm.
And of course, the breast is gone, so it lowers your risk to the lowest amount possible, but your risk is never 0%. So before you remove that breast, you want all of your information. You want to be informed as to the pros and cons of why you need, if you want to remove the breast, but you don't want your surgeon pushing you into removing it or talking you out of it. You have to be at peace with your decision. It is not a wrong thing to remove a breast. If I had breast cancer because of my elevated risk for breast cancer, my risk for breast cancer right now is 40 something percent. So I can do prophylactic mastectomies. So if I would have breast cancer in one breast, of course I'm going to remove both breasts because it would give me peace of mind. But at the end of the day, you have to have all of your information and your be informed so you can make a good decision. And I don't like when patients are scared into making decisions. And it's not an emergency. Just because you get diagnosed with breast cancer does not mean you have to have surgery the next day. Patients, I tell patients it is a mental emergency because you know you have breast cancer, but it's not a surgical emergency. There are very few surgical emergencies for breast. Okay. So just because you get diagnosed with it doesn't mean you have to make a decision that day. Sometimes you need time to process before you make final surgical decisions. And if any doctor's trying to force you into making a decision within 24 to 48 hours, you probably need to get another doctor.
So can we talk about that for a second? Because when you're facing breast cancer surgery, some of the things that I learned and why I started this is being empowered by asking questions about, for instance, getting a genomic test. I asked my breast surgeon about that, and someone told me about that. And what does that do? By
Well, it
asking.
doesn't change. It doesn't change the surgery, so your breast surgeon probably wouldn't have ordered it. That's a medical oncology thing. So it
Okay.
would be I'm not going to say it's inappropriate for us to order it because we order it sometimes, but that a genomic test talks about the aggressiveness of the breast cancer and whether
Right.
you need systemic treatment, meaning do you need to have chemotherapy? It gives you an actual number saying you would benefit or not benefit from chemotherapy. For most patients, we don't do genomic testing before surgery. You need the whole tumor out to look at so you can have the whole thing genomically
Oh,
tested.
okay.
So your doctor probably wouldn't have done that. Now we
Okay.
do genomic testing for certain reasons before surgery. Let's say a lady has a very large tumor that's responsive to hormones, meaning her breast cancer responds to estrogen and progesterone. And she really doesn't want to do chemotherapy. Some of those patients don't really, their chemotherapy sometimes is ineffective for those particular cancers. So we do genomic testing. I'm going to use the name of two of them, mammoprint or oncotype, to determine if they would benefit. And if they don't benefit from chemotherapy, we actually put those patients on endocrine therapy, like, the hormone blockers before
Mhm.
surgery so they can shrink their tumor down. So it works in certain cases, but for the most part, genomic testing is usually done after the surgery so we can determine what treatment you will need. It does not change usually your surgical decision making. And that's something I have to tell patients.
Mm.
Removing the breast does not change whether you need chemotherapy.
Wow, that's a lot to take in. So I know when I got my surgery, my breast surgeon talked to me about a blue dye.
Mm-hmm.
Okay. And I still don't quite understand it, but I found it fascinating. Can you talk about what this blue dye tracer
Well,
is and how it
well, you
helps?
got to go back. You got to go back to the beginning. So what she's talking about is how we identify lymph nodes for invasive cancers. We don't typically take out lymph nodes for stage 0 breast cancer. But for any cancer that's invasive, depending upon your age, because we've gotten away from taking lymph nodes out of older ladies for various reasons, and we don't That's not something we need to get into right now because that's more
Mhm.
advanced. But for the most part, standard of care is you take out lymph nodes at the time of surgery for an invasive cancer, whether you remove the breast or whether you do a lumpectomy. Because the idea is if you have invasive cancer, those cancer cells can travel through the little network called lymphatics, which I call the highway of the breast, and they can end up in the lymph nodes. Lymph nodes drain the breast of fluid, and I always call them the gutters. Like when you're looking at rainwater, the lymph nodes are the things catching the leaves, so they catch the cancer cells. Back in the day, I would say they discovered the sentinel node biopsy in the 1990s is when they decided to start doing it. But prior to that, every lymph node got taken out of you that we could get out of you because we thought it was going to impact your survival and make you live longer. What we realized is that a lot of those ladies didn't even have cancer in those lymph nodes, and they ended up with permanent lymphedema or arm swelling. So they didn't benefit from having all the lymph nodes taken out. So Dr. Veronese and his team created something called the sentinel lymph node, meaning the first draining lymph node. So the idea was if cancer cells, not that you have cancer going in a lymph node, but if cancer were to travel to any lymph nodes, the first few nodes that drain the breast would be those lymph nodes that you check. So we're not psychic. We can't just decide which lymph nodes they are. So he came up with a technique, and actually, it's not just blue dye. A lot of surgeons do dual tracing, meaning we use radioactivity and blue dye, but you could do either or. The blue dye is either lymphozurin blue or methylene blue. There certain surgeons use one type, certain surgeons use another, but it's basically blue dye. But after you go to sleep, we inject it in at the tumor site or underneath the nipple, and it actually mimics the route cancer would take. And I always tell patients it doesn't mean cancer's there; it's just going the same highway towards the lymph nodes. So that when I look under the lymph nodes, if the lymph node is blue, it tells me this is the lymph node that you should take out to send to the pathologist to see if there's cancer there instead of you just guessing what lymph nodes to take out. And people have varying amounts of sentinel nodes. Sentinel means first draining. So some people have one, two, some people have three, four, but we don't take all the lymph nodes out. And then the radiologist or your breast surgeon may inject radioactivity in the breast. I think the newer type is called lymphoseek, but it's basically a radionucleotide. It's taken up, we inject it at the tumor site or at the nipple, just like the blue dye, and it travels that same route. And instead of the lymph node being blue, you have a wand that we use. There are various companies that make this wand, but it's like a Geiger counter. It picks up the radioactivity in the lymph nodes, so you can hear the actual activity of the nuclear medicine. It makes a little noise, and that's the lymph node that you know to take out. So it's like beeping at you. I like dual tracing because I think that lowers the risk of getting lymphedema. Plus, it also, to me, makes sure it's more accurate. So not only do I have radioactivity injected by the nuclear med people, I do blue dye when the patient goes to sleep. So I have a blue lymph node that's radioactive, or either I have a radioactive lymph node or I have a blue lymph node. Like I have dual tracing so I can make sure I'm very precise. But the sentinel node is very important because if it has cancer cells in there, traditionally we used to take you back to take more lymph nodes out. Now things have changed where when certain patients, I'm not saying every patient, certain patients may be able to be spared having a full axillary node dissection, meaning taking all the rest of the lymph nodes out if they're going to get radiation or other types of treatment. So that's why it's so important that people are a part of a system that maybe has multidisciplinary, so you can have a tumor board if you can, because not the surgeon, a tumor board means you have, yeah, so a tumor board means not everybody has a tumor board, so, sometimes you don't. But the tumor board has the breast surgeon, the medical oncologist, the radiation oncologist, the geneticist, you have the researchers, everybody's, in a room or online discussing a particular patient to decide what's going to be the best course of action. So for me, if a patient has a lymph node that's positive, I will normally talk to my radiation oncologist to say, hey, do you feel I need to take out more lymph nodes? Is that going to impact her survival? Or can we do radiation instead? There are certain criteria why we take out extra lymph nodes. I won't get into all that because that's not something somebody needs to know on this level. But just know, just because your lymph nodes have cancer in them does not necessarily mean You're going to need chemotherapy, or you're going to need more lymph nodes taken out. So that's why it's so important to have a very good discussion with your surgeon and your medical oncologist to determine what your next course of action will be.
Interesting. I
And
will share.
standard is, well, I will say standard of care is changing. So you want to make sure whoever you're seeing is staying up on how breast cancer treatment changes so rapidly. It really does. So the things that we were doing when I was a fellow, when I was training in breast surgery back in 2010, that's when that study came out saying if you had a positive lymph node and somebody kept the breast, just did a lumpectomy, you didn't necessarily have to take them back. It was controversial. People were yelling at each other at tumor board. I mean, it was bad because people said you should take the lymph nodes out. We realized that a lot of those patients didn't need to have them taken out. And we've got data showing that they had very low risk for recurrence in the axilla. So things change rapidly. So just because you have positive lymph nodes does not mean necessarily going to have to do chemotherapy. That's where that genomic testing comes in, actually. For hormone positive patients who have like one or two lymph nodes, or especially just one lymph node, they can do the oncotype on them to determine if chemotherapy is going to be beneficial. So that's why genomic testing is important for decision making like that. So your medical oncologist, will usually go before a tumor board and you all decide what's going to be the next course of action. It's not one person making your decisions. It's usually a group of doctors coming up with the best plan for you, a personalized care plan.
So I just want to share personally, I had a micrometastases, which I want to explain what that is, a small group of cancer cells under 200. Is that correct?
Yes. It's
In,
very
in,
tiny, but it doesn't mean you need chemotherapy though.
but when I had my surgery, I had clear margins. And so clear
Well, that
margin,
has nothing to do with your micrometastasis, zero things to do with that. That's just the cancer has gotten out of the breast into the, but yeah, we would expect you to have clear margins because you had a mastectomy. It's very seldom, unless your cancer is touching your skin or touching the muscle, because we're doing a mastectomy, most women are not getting positive margins for a mastectomy. It can happen, but your margins were expected to be clear because you had a huge operation.
and what does a clear margin actually mean for those
So
that don't?
we clear margins mean that you don't have cancer cells near the edge of whatever we take out. It's really critical for patients who are getting lumpectomies, real honestly. We care about mastectomies too, but for a lumpectomy, because we are conserving the breast, meaning we are just going in and taking the cancer out. For invasive cancers, we want to make sure that when they take that, we take the tumor out and the pathologist is putting ink on it to determine what side is what, meaning, they look at something called the anterior margin, what's the front of the tumor, what's behind the tumor, what's on the side, what's superior, what's inferior. If cancer cells are sitting out, at the edge of that, that means we may have left cancer cells behind and we need to take you back to take more tissue out. But we've gotten away from that. Now, if you have invasive cancer, as long as there's no ink on the tumor, we don't take you back anymore. That's how rapidly breast cancer surgery has changed. But for non-invasive cancers, meaning the cancer that's called DCIS, ductal carcinoma in situ, your margins really need to be greater than 2 millimeters. So if I get a report back that you had that cancer, and that's at the edge, left, it's less than 2 millimeters, we usually take you back to reduce your risk for cancer coming back. So positive margins are really important for making sure you have local control, meaning cancer does not come back, of what we took out. So for a mastectomy, you can, if you have a very large cancer that's touching, the skin, there's a possibility you could have little cancer cells left behind. Sometimes we take you back and remove skin. A lot of times we discuss in a multidisciplinary conference whether or not we need to take you back to surgery or can we do radiation. But for the most part, the mastectomies, unless it's some kind of craziness, they usually, I'm not gonna say usually, but we don't really expect positive margins for mastectomies. It can happen, but we really get concerned over lumpectomies because we have to do more surgery.
And so another question I have for you is the drains. We have to get drains. Why do we have to get drains?
You
And I
don't
know,
have to get drained. You can just have a seroma and we keep draining you. That's what I tell my patients. They all groan about the drains. I said, you can just have a seroma and I keep draining you. The same lymphatics that drain the breast that go to those lymph nodes are the same lymphatics that are running throughout the breast. When we remove it, they leak into the breast for 7 to 10 days. So they have to seal off, and everybody has varying degrees of how fast they seal. Now, I have not had a surgeon not put a drain in for a mastectomy that I know of. but we don't keep them in forever. We used to keep them in for 7 to 10 days because we don't want you to fill up with the seroma or the fluid that leaks out of those lymphatics. It's just uncomfortable. We have to drain the fluid. And if you're flat, like you are, or like some women are want to be flat, if you have fluid there, that chest wall can't be flat. And so it can become a chronic condition. So you want to put drains in. I know they're annoying. They're the worst part of the whole procedure. No one likes the drains. I had 2 drains around my kidney after I had my partial nephrectomy for kidney cancer. And the fellow came to take them out and said, "Oh, it won't hurt." I said, "You're lying. They hurt." Temporarily.
Yeah.
Drains suck, but they are a necessary evil. But yes, the drains are necessary because the lymphatics leak into that mastectomy space. And if you're getting reconstruction, we don't want fluid bathing the implant.
Okay.
So that's why we put
So,
drains in that as well.
so let's talk about reconstruction because this is a big part of my why I'm doing this to make sure that women are empowered to know all their options. I was under a unique situation where the plastic surgeon wasn't available at the time of my double mastectomy. And so they said, "Do you want to wait 3 months?" And I said, "No,
Wait,
let's get
3 months to wait for surgery? Goodness.
for plastic surgery so he could be available at the same time." So
Wow.
yeah, it was kind of crazy. And it all kind of worked out, but I was not presented aesthetic flat closure. So there is a whole push on social media about making sure that, and everywhere, that women are aware that this is a healthy, beautiful option for women to consider. So I think most people, at least I felt this way, that the natural course of action is you're going to reconstruct. So can you talk about, and especially in your experience with aesthetic flat closure, and what exactly that means and how a woman really needs to be empowered about their decisions and a lot of choices right out of the gate. You're going for a double mastectomy or even a lumpectomy. There are choices. There's oncoplastic surgery. There's, aesthetic flat closure. There's plastic surgery. There's deep flap. I mean, there's just a lot of options. So you're the first line of what we come to when we're dealing with this, the surgeon, if we're getting surgery. But can you touch on kind of just the empowering women to understand, especially aesthetic flat closure, because there's a lot of women who have gone in and asked for that and don't come out with that. So I know that happens a lot. So
Well, in your breast surgeon's defense, the reason why he or she, I don't know if you had a male or female, but the
yeah,
reason why they did not tell you about it is because they did it. That is not a movement. That movement just came about recently. Most
okay,
breast surgeons, well, I'll say a lot of breast surgeons, we make you flat anyway. Like we know how to do that. So we
yes,
don't even discuss it with you because we know in order for you to wear a prosthesis, we don't leave you a lot of skin, fatty
yes,
tissue hanging off of you because we make you flat. I didn't know it was called flat aesthetic closure until probably, oh gosh, 2020, because I did it anyway. But what
wow,
that means is because we make you, that's what we do. But
okay,
what that means is making sure that whoever's doing your surgery, if you do not want to be reconstructed, is removing excess skin and fat so
mm,
you can be as flat as possible and not having, a lot of
dog,
bulges and
yeah,
irregularity, that axillate, that fat pad over here.
yeah,
We call it dog ears. It looks like a little dog ear, making you as flat as possible. The problem is some people have never been taught how to do that, your surgeons. So they just remove the breast and leave skin and tissue and they close you up. So there's no way, the patient has to be empowered to go in and say, "Hey, I don't want to be reconstructed. I want to be flat." And you're going to be flat because we're taking the breast off. But you have to give them a clear picture. I want flat aesthetic closure. That means when you do my surgery, I'm not left with a lot of excess skin. I'm not left with a lot of excess fat. And I don't need you to make a decision for me because what happened with
Kimberly,
what's her name? Well, I forget.
Kimberly, not putting on
Yeah,
a
but
shirt.
the name not putting on a shirt. The founder, but that was she was almost shamed into being flat
Mhm.
because her surgeon made the decision to leave her with skin because he wanted her to be reconstructed. Before you go to sleep for surgery, there has to be a clear understanding and a clear line of communication that I don't desire reconstruction and I'm not going to desire reconstruction in the future. So I don't want you to leave me with any excess skin for reconstruction. And it's wrong for a surgeon to make that decision for a patient, to try to bully them into reconstruction. And I will tell you, flat aesthetic closure Making that patient flat takes the longest portion of a mastectomy. It really does. I can remove the breast in 15 minutes, no issue. But to close that patient completely flat, because we're sitting there cutting off excess skin and sewing up at the same time. I won't even let my assistant sew when I'm doing flat aesthetic closure, because I know what needs to be removed and how to get it to smooth out. We're measuring things. I'm cutting off excess skin. That can take up to an additional 45 minutes because you want it to look a certain way. So it is sometimes time consuming, sometimes it's not. But we didn't get trained to do that. That's not something that's in our training for general surgery or even our fellowship. We just learn how to make people flat. But there are courses now that actually train surgeons, whether you're a breast surgeon or a general surgeon, to do flat aesthetic closure and give you helpful hints on how to keep the person from having dog ears and things like that. So that patient, when they go in to see the surgeon, they may want to take pictures, things from the website, and go, hey, I want to be flat and I want to look like this. Are you able to do that? Now, if they can't, they can work in conjunction with a plastic surgeon who can hopefully make you flat. But for the most part, we do it by ourselves. But the patients you have to have a surgeon that is willing to do it. And we call them flat friendly surgeons. And they have to have an awareness that this actually exists. The second thing is for reconstruction. When patients come in and they want to have mastectomies, I always, and especially if they want both breasts removed, I always ask, are you interested in reconstruction? I think that should always be presented to a patient. Now, if you're 100, we're not going to give you reconstruction. I'm not even going to ask you about it. But some of my 76-year-olds are very healthy. They have good skin and they want to at least visit with the plastic surgeon. Even if I know the plastic surgeon is going to say no, who am I to deny them going to see the plastic surgeon? I mean, I will say, I don't think you're a good candidate, but I'm not the plastic surgeon. So you have the right to go sit with the plastic surgeon to get the information that you need. But it's up to us to make sure that you get that information, because in some towns in South Arkansas, they don't have plastic surgeons. So when the woman goes in to have surgery, basically they're just flat because they don't have that option. But if you have access to a plastic surgeon, you can just refer that person on to a center that has one, so they can have all their options presented to them. When we talk about reconstruction, there are multiple ways to reconstruct, and I'm not a plastic surgeon, so I'm not going to get very specific. But, sometimes we put in implants in, sometimes they're silicone, sometimes they're water-based, and the plastic surgeon has to decide what's good for you. Then there are centers that do flap reconstruction, which is called autologous reconstruction, meaning they take tissue from your back, which is the latissimus flap, and they swing it around to make a breast, or they take tissue from your stomach. So there are multiple ways to reconstruct a patient. You just have to ask, okay, number one, I want reconstruction. Do you have a plastic surgeon that you work with, and can I meet with them? But I don't think a person should be forced into surgery until they make sure that they make a good decision. So what I tell patients, they will tell me, I'll say, well, we can take it off, but sometimes we can't put it back on if you don't like it's hard. It's not gonna be made the way God. We gotta be realistic. We tell everybody we can make you look beautiful, but it's not the same. So I had a patient with an 8 mm tumor, very tiny tumor, can easily conserve her breast. Did not want to lose her breast, but start having nightmares about having recurrent cancer. So she called me and said, I really want both breasts removed. It's not for me. I told her all of her options. I thought she'd be excellent to conserve her breast, but she just didn't feel comfortable doing it. It's not for me to stop her and say, I'm not going to operate on you if you don't conserve your breast. She wanted reconstruction. That's what we did. So I think you should be presenting all your options before you make a decision on surgery. Now, I will tell my patients, I don't mind if you take time to make a decision, but after, a few days, few weeks, I start calling you and we don't even be taking that long now. I started getting on you. But I don't think you should be scared into a decision. Like when I come in and talk to a patient, and I know this from my own being diagnosed with kidney cancer. When you're in disbelief that you have cancer and you're sitting in the room, or you're just being told you have cancer, you don't hear anything after they give you that diagnosis. And especially as that doctor is drawing pictures and talking about your actual cancer, you're in a fog. You really are in a fog. So when all of a sudden they get to the surgical portion and you got to make a decision on surgery, you're like a deer in headlights. My uro-oncologist asked me after talking for 45 minutes, all I saw was kidney diagrams and this is how he was going to get the tumor out and this. don't remember anything that man said to me, except for I was thinking, I don't have cancer. This man read the wrong person's reports. But at the very end, he goes, do you have any questions? And the only question I asked him was, could I still take my cruise? I had no other questions for him. I didn't hear a thing that man said. My mom was taking notes and she was listening because I was still in disbelief and shock. I was not at a point where I could make a decision on what kind of surgery I was going to, or what surgery I was going to sign up for. He gave me options for what I needed to have done, but I couldn't think at that point. So after I give initial diagnosis of cancer and I'm talking to the patients about what their tumor markers are, yes, you need chemotherapy before. We're going to do genetic testing. The medical oncologist may do genomic testing. It's so much information. I give them an overview of what surgery I think they need, how we're going to get to that point, the people they need to see, and I let them think about it. I usually give my patients my number and give them a day or two to think about things so they can make good decisions. And I let them see everybody. I let them see the radiation oncologist first, so if they want to conserve the breast, I let them see the medical oncologist when I think they need chemotherapy first. So I let them see different people. So when they come back to see me, they have a good decision, their informed decision making is
So
very important.
as I listen to you, I just think that, the anxiety around all of this is one of the reasons why I started this, because I want to pave the way for anyone sitting here at night, knowing that they're going through this, that they have time to process. We only get an hour with the breast surgeon, and you are, in my opinion, the first line of defense or whatever you want to call it. And it's not enough time. And I had someone with me as well, and I didn't hear any of it. I think the shock, all I wanted was it out. And
Yeah.
so I rushed and I was like, do you have a cancellation? Get me in. So let's talk about the anxiety, because the surgery is so anxiety provoking, everything about it. And through our conversations, you have shared with me that you say to your patients, take a deep breath. And I really think it's important that, if you don't have a doctor that speaks that way, just hearing you say that is going to be very comforting. I could have used that the night before. I was in tears, and
No.
I was a mess. I was crying. I even took pictures, you know, because I think also recognizing that for some of us, we didn't have a choice. This was the
Yeah.
only way to stay alive. So, with that being said, the emotional side of what this
Yeah.
disease brings to any woman who's facing this, first I send love and hugs to anyone. And I want you to know that Dr. Robertson's approach is so emotionally comforting. And what is it that you say? The best patient?
Well, first of all, I look at before I go in the room, I look at their pathology report. If I see it, I'm going to speak a lot of jargon right now, but if I see a person's that has a small cancer and it's hormone receptor driven, grade 1, meaning it's not a fast growing cancer, and I see that everything is ERPR positive, HER2 negative, if you're a breast cancer survivor, you know what all that means. I smile. They have the best of the worst. I don't say I don't go and get a good cancer. No, cancer is good. You wouldn't hear that. But you have the best of the worst, because nobody wants cancer. Breast cancer is the worst. Cancer is the worst, but you have the best of the worst. Before I start a discussion with that patient, I go in and see how anxious they are. They're wringing their hands. You can tell when a patient's just ain't, you walk in the room, their blood pressure is 189 when you walk in. I don't even go into, I usually put the paper down and I introduce myself and I get their hands and I say, I need you to take a deep breath and blow it out. And they look at me crazy, but after about the third time of me saying it, they do it. I said, because you won't hear anything that I'm saying and I need you to listen to me. They do it and I have them take deep breaths. And then I go, now let's talk about your pathology. Number one, you have before I even get into the specifics, because I draw pictures, I go through everything, but I give them a quick overview so they can listen to me. I say, you have an early stage breast cancer. It's very responsive to hormones, which is a good thing. It's slow growing, and you are going to do fine. And then they start to relax. I say, now we can talk about your cancer. Even when they have aggressive cancers, triple negative or HER2, I'll come in and I'll have them calm down, say, now listen, you have a cancer that we don't like and it has aggressive features to it. And you're probably going to need chemotherapy even before I do your surgery. but we're not doing chemotherapy because we think you're going to die or trying to keep you alive. This is because this is a necessary means to an end so that you can be here dancing at your son's wedding or their graduation. So take a deep breath and listen to me because you're going to beat this, but you're going to have to do things you're not going to like in order to make that happen. And they calm down too. It's a way you can approach a patient. That's
nice.
something that can't be taught.
Yeah.
I can't,
No,
you can't,
it's
it's
yeah,
just something that's
your
inside of the
special way.
physician. So not everybody's going to get that.
Yeah.
So what I tell patients is that if you don't get, I do a lot of second opinions. Um, and an example would be I had a second opinion. I thought it was because the person, I honestly don't know. When my thought process was this person wants me just to do their surgery just because they heard I could do this type of surgery. Well, honestly, they didn't even understand they were getting chemotherapy before surgery. And all they wanted to know was how was a lumpectomy done? Something very simple. How would you do the lumpectomy? Well, you do this, and this. Because their prior surgeon just will say, you get a lumpectomy and would be bothered when they start talking about, well, what does that entail? It's a lumpectomy. We're just taking the cancer out. Something as simple as me spending 5 minutes describing the surgery was enough for them to be, okay, well, you do my surgery. So you never know what that patient needs to hear. You just have to ask the patient, tell me what's going on, what's going through your mind. And that's usually what I do. I stop and say, tell me what's going through your mind. I think I'm going to die. I say, no, you're not going to die. You may die one day, get hit by a bus, but the cancer's not going to kill you. They usually laugh.
Yeah, that's great.
But that can't be taught. So your surgeon needs to be empathetic. I think I would say sympathetic. Unless you can't really be empathetic if you've never had cancer before. So I know how it feels to sit on that other chair,
Yes, you do.
where you're being told you have a diagnosis, because I'm understanding that you don't hear everything.
Mhm.
And yes, it may be a easy to treat breast cancer, but you don't know that. You've never been through cancer before. So I let my patients grieve the loss of their life. I call it BC and AC. BC is your life before cancer. AC is after cancer. I allow them grace to grieve their life before cancer. And I don't grieve anymore, but I grieve my life before cancer because that's what you'd have to get scans, normal life before gene mutations and things like that, where you didn't have to think about stuff like that. So another thing is after the cancer diagnosis and they've been treated, something that we have to really understand is, I would say, caregivers and family members, not so much the physicians, is that even though you've done well from your treatment, it's still a part of you. So what happens is usually your family and friends will be very supportive while you're going through everything. But once you've gone to your last chemo, your last surgical visit, it's like everybody just disappears. And that person's still struggling mentally. There is not a day that you don't know you didn't have cancer.
Yes.
You see your scars. I see my big scar on the side of my flank. People have scars on their chest. You always see that your body's different. And so it's always a reminder. And they call it a pink badge of honor or a badge of honor, but you have to understand. And sometimes the family members will come in, why isn't she over this, doc? Well, I wouldn't say you wouldn't get over cancer because you have a new normal. Or why isn't she back to normal? It's a new normal. And I always add, I don't go in and say, have you gotten back to normal to my patients? Because it's not the same. I go, have you gotten back to a new normal? Because you don't feel the same. You don't have breasts anymore. You may have had radiation changes to your lumpectomy site. Even if we make the breast as beautiful as possible, sometimes you still have shooting, shock, and pain. You have implants in place. So, things are not the same. So people have to give patients grace that things have changed, but you also have to give them hope that they're going to do fine. And they have to we learn how to accept this new change. I guess that's the best way to put it.
I think I appreciate, and I'm sure many and anyone who's listening, just the emotional, and that's one of the reasons why I wanted to do this, because I don't think the emotional side of the human being is really addressed on this journey, and it is so very fast. Bring up a good point, even a lumpectomy. These are words, and I work with a lot of people who are part of the Learn, Look, Locate mission to teach them how to talk to us. We don't know anything. We are walking into almost, I'd put it at a level of almost a small college education of terms because we're dealing with our life. So,
One of my pet peeves is when I ask a patient who's coming to see me for a second opinion, well, what kind of breast cancer do you have? I don't know. Does it respond to hormones? What is that? They just told me I need a surgery.
Oh, no.
No, actually, you need chemotherapy first. Or I need chemo. I don't know. Why do I need chemo? Like they didn't go through anything with them. Are they calling? They walk in the room and go, "You have invasive ductal carcinoma, grade 3, ERP or positive, HER2 negative. You're gonna do fine. We're gonna do a lumpectomy," and they walk out. And the patient's like, "I got cancer."
It's a lot for us to process. And I
It's
just,
like your little ant, and we're giving you water from a fire hose. Is how I describe it.
yes, yes, let's just call it what it is. And I know just getting out there, people feel that way. It's very true. And I just don't think it's, there's not enough time for us to process all the decisions. There's not enough time for us to understand it all. And in closing, I do want to ask you, with the whole breast cancer surgery, we're going to be working together so people know on a lot of questions. I know there's a lot more questions. This is a big deal to go through breast cancer surgery. But do you have a closing thought for anyone listening about breast cancer surgery? Just your,
I just
you
can
know,
give you my philosophy. I tell a patient, I'll do whatever you want as long as it's oncologically safe. And oncologically safe means we're not leaving you with cancer.
okay.
So if a patient wants to have a lumpectomy and we're not going to leave them with breast cancer, I don't have an issue with that. If it's a
Mhm,
tiny cancer and they want both breasts removed, as long as they're at peace, first of all, we have to make sure we're not leaving cancer, and
mhm,
we have to make sure you're at peace with your decision.
gotcha.
If you're not at peace with your decision, after I told you you can do either a mastectomy or a lumpectomy, then we need to take a step back until you get peace with it. Because the worst thing in the
Right.
world is to do the wrong surgery for an emotional reason.
Yeah, yeah.
I always say I can take them off, but I can't put them back on just like God made them. But what I do also tell patients is if you do a lumpectomy first and you get the lumpectomy, you see what the cancer is. Do I need systemic treatment? And then if you're okay and you don't need additional treatment, you can always get a mastectomy at a later date. You don't have to make that decision right then and there.
Good to know. That's really
Especially if you just, but what I'm going to tell you is breast cancer is not a surgical emergency most time. We barely ever have a patient come in bleeding out from
helpful.
breast
Okay.
cancers. You got some time to make decisions, but we don't want you to take forever to make a decision. But if you feel like you're being rushed into a decision or it's okay to get second opinions. I
Mm-hmm.
think that's something that you feel guilty for
Mm-hmm.
sometimes because this is the
Mm-hmm.
person that
Yeah.
diagnosed me with breast cancer. But if you're not getting what you need, and I
Yeah.
tell patients all the time, you can my patient is going to get has already set up an appointment. I just saw her yesterday, but she already had an appointment for MD Anderson. I completely support that
Yeah.
because if she hears that they are doing the same thing we're doing, she's probably going to come right back and have her surgery with us. But
Yeah.
I got a second opinion. It is okay to get a second opinion. Now, when you get to the fifth opinion, I'm going to look at you crazy. Come on
Yeah.
now. It's time to make a decision. But
Yeah.
yeah, it's okay to get a second opinion, and you need to have time to process. The other thing is if you go to an appointment, because there's so much information, have a second pair of ears there. You really
Oh,
shouldn't go
that's
to these
really good
appointments by
advice.
yourself
Yeah. Yeah.
because it's so much information and there are things that you miss, and your family needs to be involved. I, I wouldn't say with the decision making process because ultimately it's your
Just
decision,
listening. Yeah.
but listening so you understand why the doctor's recommending, why the doctor's recommending
Yeah.
the particular procedure or chemotherapy or radiation, and also so that you can, if things that you missed, that family member or close personal friend can ask those questions or write down stuff for you.
Yeah. Well, I can't thank you enough. I mean, this is priceless. As we said earlier, I mean, there is so much information to process, truly understanding what's ahead of you and trying to, I like to say that the knowledge is calming. For me, it was. I wish I knew so much more than I know now at the time before my
Oh, and
surgery.
stay off Google.
Off Google, out here with us, So, I mean, there's just,
Reputable sites, please. Reputable sites.
it can
Google
scare
scares
you.
you. I will
Yeah.
say this. Patients who have the aggressive cancer, triple negative breast cancer, when you hear it, it strikes fear in the hearts of everyone.
Yes.
But we have so many good treatments for triple negative breast cancer now, even though it's still one of the more aggressive cancers, that when
Yes.
you Google it, of course, it looks like you're going to die tomorrow.
Yeah.
But I tell patients stay off Google and trust we have good medicines to take care of your cancer.
That's
So
awesome.
be careful what you look at. And that's why I always recommend I write down different websites. Susan G. Komen, Learn to Locate, breastcancer.org. There are different organizations that are very reputable that you can go through your cancer diagnosis and get good information so it doesn't terrify you.
Well, thank you, Dr. Robertson. It's really been a pleasure. We're so grateful for your time today. And I hope you enjoy her page here. It's all about breast cancer surgery. I'm honored to have you.